So I do want to talk about the challenge of making real-world impacts with research on women and children. I have been doing this kind of work for many decades. I started my career at Johns Hopkins, and they actually have a Women and Children's Center there as well. When I was at Johns Hopkins, I was a very good academic, trained to talk to other academics, to be evaluated by other academics. And when you do that and have academics as your primary audience for your work, you don't really have an opportunity to make much of an impact. I was recruited to direct a Center for Research on Inner City Health, which has been renamed Center for Urban Health Solutions, and there with the mission of reducing urban health inequalities through innovative research solutions. Have had the opportunity to have at least half my research or more, and many of the scientists as well, half their research or more, have an immediate direct impact on practice and policy. So I would love to share some of the lessons that I've learned in that process of being able to change up my research. So the key messages, and I'm lucky I have three that I want to talk about today, focuses on the issue of inequalities, because inequalities really is an important issue, and there's a corresponding interest in ensuring that research plays a role in addressing inequalities. But research describing problems, which we have in abundance, rarely makes an impact. And research that generates evidence about solutions is unfortunately still all too rare. So we're going to need different approaches to ensure that evidence informs programs and policies to address the growing inequality gaps. So let's begin by talking about the issue of inequalities. Since 2008, when the Commission on the Social Determinants of Health launched their landmark report on closing the gap in a generation, there's been a number of reports which have come out, sometimes it feels like monthly, on documenting the extent to which inequalities exist globally, within the country, within cities, the nature of the inequalities, how it affects different populations. Too many reports to actually be able to describe them. But I think the message is fairly common across these reports, that inequalities are pervasive, documented in every country, that they are related to poor health for everybody, not just those at the bottom of the inequality spectrum, and that the inequalities are growing and that immediate action is needed. Some of the data that we see from some of these reports, so this is data from UNICEF, where they related different levels of inequalities in different countries. The countries on the right are the high inequality, you can't see it, slides cut off, and low inequality, and you can see that there's a pretty straight line correlation between high and low level of inequality and level of performance on the index of child well-being, which is about health, which is about education, which is about safety for children. So we can see, unfortunately, that the US is down here at the bottom with very high levels of inequality and performing poorly on the index. We can also take in the statistic that was recently published that suggests that looking at data over a 50-year period, when we compare the United States with its peer countries in rich, in wealthy settings, that because of the lack of social support and high rates of poverty, that there have been in excess of about 600,000 children deaths over 50 years because of the growing and level of inequalities in the US compared to other countries. We can also see that inequalities are not necessarily stagnant. There can be changes in inequality. So these are the same countries looking at changes in the Gini coefficient from the period 2000 to 2009. And when there have been improvements, which on the far left there is more equal. So these countries have gotten more equal over that time period. There have been corresponding improvements in the performance on the index of child well-being. These data are over many years, over many countries, and so it's hard to argue with the fact that inequalities are related to health and well-being among children. When we look at cities within the states, we can see that Atlanta doesn't necessarily have a good standing. These are data from 2010 showing that Atlanta might be #1 in income inequality. There's some more recent data from 2013 that suggests that Atlanta is getting better. It's now #3. But one thing you can't see on this slide, sorry, my slides are cut off, is that the ratio of those, the income held by those at the top versus those at the bottom is about 17.5. So it's still quite high. Sometimes people think that inequality is really just a proxy for poverty or low income, but in fact, it's not, and inequality may be more important in determining health and well-being than poverty. So these are data from 282 metropolitan areas showing levels of all-cause mortality. Now, this is not children, so this is all-cause mortality for adults. When the bar is higher, it's worse. And this is showing data for the cities according to 2 dimensions. One is the level of inequality or equality along the front, with the far left being cities that are relatively equal. The blue bars are for cities that are in the highest quartile of average income, and the red bars are for cities that are in the lowest quartile of average income. So you can see that by income, if we compare the red and the blue bars for each level of equality, we do see some gradients that we might expect. Those with lowest income have higher mortality than those in the blue bars with highest income, but the strongest gradients are really by levels of equality. So you can see a sharp slope across the levels of inequality, so much so that even if you are a low average income city, that is this red bar, I think, does this work here any better? No, it doesn't. Okay. So the red bar here, these are cities with a low average income. They actually have a better all-cause mortality than the wealthier cities in the highest inequality areas. So this slope here is very strong. So it's really inequality that is driving the levels of all-cause mortality and not so much levels of average income for each of the cities. So inequalities do not only impact the poor, they actually follow a gradient across all of the socioeconomic spectrum. Also, inequalities are not fixed or stagnant, and they are the consequence of historical and contemporary policies and societal practices, which means that they can and should be changed. So we should be focusing on inequalities because they are unfair, it's part of the definition, and they can be changed, and we should be addressing them because they are very much a determinant of health, maybe more so than poverty. So what role can research and evidence play in helping to reduce inequalities? So there's 3 things I'd like to focus on. First, I think research should do a better job of focusing on the root causes of inequities. We should also be focusing on solutions. And then finally, we should ensure that the best interventions that are available are effectively implemented. So I'd like to go back to that report issued by the Commission on the Social Determinants of Health. I suspect that many of you have seen this particular framework because they also issued a theoretical framework or a conceptual framework about how the social determinants are causing the health status of populations and also levels of equity in a society. And I think the main thing to pay attention to in this graph, even though it's quite busy and it has a lot of factors that we've seen in many of our studies, from health behaviors to psychosocial factors to material circumstances, is that the social determinants are divided into 2 groups. The intermediary determinants of health, which again are the psychosocial factors, even the healthcare system factors fall in the intermediary determinants of health. And then there's the structural determinants of health, which include things like social policies, labor market policies, housing policy, macroeconomic policies and governance, the political system. So those all fall into the structural determinants of health. And according to Professor Sir Michael Marmot, the structural determinants of health are not just the causes of the causes, but according to him, they are the causes of the causes of the causes. So they are the root causes of inequalities in society. And that's really what we should be focusing on if we want to make a difference in the inequalities. Our research, however, tends to focus on the intermediary determinants of health. When I think about the areas that I'm interested in, whether it's women's mental health or intimate partner violence, most often the studies focus on determinants that are the intermediary determinants of health. In fact, I did a quick look at the 2017 published literature on inequalities and found that most of the research actually falls in the intermediary determinants of health. So you want to take a guess? How many people think that it's 50-50? The research, half of them are focusing on the structural determinants and half of them focusing on the intermediary determinants. No takers for that. Okay, how about 25%, 25% structural, 75% intermediary? Yes, you think so? Okay, so one. How about 10% structural, 90% intermediary?
Closer.
Closer. Yeah, so it's really about 2% and 98%. And that hasn't changed. So I looked a couple of years ago, and it was about 2% then as well. So I think we need to do a better balance of being able to focus on structural determinants, but there are limitations that are kind of built into the kind of data systems that we usually have access to as epidemiologists. So some of the major sources of the data that we use for women and children's health encourage a focus on individuals. So we might look at vital records, national surveys, administrative or medical data, or billing data. And that has information on individuals. Rarely do these data sets contain information on some of those structural determinants of health that are listed here in this conceptual framework. And there's consequences to that for our research. So I'm going to share a quick story with you that's quite an old story. It's about Baltimore City and about the Healthy Start program. We were one of the original sites. I know that Atlanta has one as well. And at that time in 1991, it was in the good old days when we had lots of money. So over about 5 years, we had $40 million to address issues of infant mortality. That's a lot of money. And the city, who was the grantee, was very willing to address the structural determinants of health. In fact, they were from the war on poverty, and they were all excited about it, but they also wanted it to be evidence-based. They wanted the interventions to be the best possible. Being a researcher on the team, they turned to me and they said, tell us what the literature says. We want to know how to spend the money. We want to know, should we be putting money into housing or in employment, and how much? 80% of it in employment, 20% in housing. We just need to know. So when I go to the literature, most of the literature actually looks at these factors in relation to infant mortality, some of the usual suspects. There really wasn't much literature that told us how the structural determinants of health, housing, labor market, social services, were either shaping the risk factors, the intermediary risk factors like employment or poverty or parenting, or how they might be directly related to infant mortality. So sadly, at that time, the literature could not tell us how to spend the money. How much do you think it's changed? Well, we saw from the last slide that there hasn't been very much change. And it's not just the health literature, actually, that suffers from this problem. The issue of not looking at the structural determinants goes beyond health and is sadly pervasive. So there was another researcher who looked at the poverty reduction literature. It's a multi-million-dollar industry. And in the 1990s, around the same time when welfare reform was going on, the research on poverty informed and shaped the way in which welfare reform was conceptualized and implemented. Alice O'Connor, in summarizing the experiences with that multi-million-dollar poverty reduction industry, found the following: that the problem was with what was being left out of research. And because of data limitations, poverty analysts rarely incorporated institutional practices, political decisions, or structural economic changes into their research. Their focus was on individuals and families. Sound familiar? She goes on to conclude that the data made it easier to think about poverty as a failure of individuals, rather than of an economy in which middle and working class, as well as officially poor Americans, faced diminishing opportunities. Those things were not in the data sets that they were analyzing. I think the lesson to be learned is that we can't solve the problem of inequality or even understand it well without data on the structural determinants. And we just need to put more effort into identifying and generating relevant structural data and methods for their analysis. And these approaches exist. We just have to use them more. Another issue that I wanted to focus on is looking at the kind of research that we do with our data. So I'd like to think that our research can, and I know this is overly simplified, but our research can probably be sorted into either problem-focused research or solution-focused research. Problem-focused meaning identifying the problems, the magnitude of the problem, defining it, sometimes looking at the associations with the social determinants. Solution-focused, on the other hand, are evaluations, program tailoring, evidence syntheses, policy analyses, and here too we tend to have an imbalance in the proportion of research, most of it being problem-focused. So when it comes to inequalities, we have lots of data that demonstrate things like low birth weight or smoking in pregnancy by different characteristics, whether it's race and ethnicity or educational status, as shown in these graphs here. And these data are limited in that they tend to focus on demonstrating the gaps, but not on identifying what their causes are or how we can design interventions in order to reduce the gaps. So if we think again about our research that might occur on a spectrum here, what we need is we need to have, well, we have problem-focused research way on the left, and then in the middle here we start to have data studies on causation or evaluations, both outcome and process. Process is very important so that we know how to replicate the program or what might have gone wrong. Economic evaluations and implementation evaluation. Once we have, for example, effective evaluations, we need to make sure that they're implemented with fidelity. In an ideal world, I think we'd still have problem description, but we wouldn't have so much of it. We'd have more research that helps implement evidence-based interventions and more research that helps identify what those evidence-based interventions are. But what we actually have, so that's what we need, but what we actually have is far more problem-focused research than we do research that helps us think about and design the solutions. Some of that is changing, and we write about that in our book about rethinking social epidemiology toward a science of change, so toward a science of helping us make change and also changing the field of social epidemiology to be focused more on solutions. And there's also calls for more evaluation and implementation science more broadly. So in epidemiology, there's now consequentialist epidemiology, which followed the publication of our book. And even more recently, there's now a new section in the American Journal of Public Health, which is focusing on intervention. So there's a call for more research on solutions. So I thought what I would do was spend a little bit of time telling you about the kind of research that I get to do that tries to bring all of this together. I want to start with some research that we've been engaged in for probably about 6 or more years now on the issue of homelessness. So homelessness is certainly a result of lack of affordable housing and also a failure to come up with the kinds of services that some of the homeless populations need. I've been involved in this project, which is actually one of the largest randomized trials on homelessness in the world, which is looking at the issue of housing first as a strategy for actually eliminating homelessness, not just managing homelessness, but eliminating homelessness. This was a randomized trial over 5 sites in Canada. So we took this one intervention and we tailored it to different sites. So for example, in Toronto, we had a large number of immigrants who were in our sample. In Winnipeg, it was a mainly Indigenous sample. So each site had a different sample and they had to tailor this housing first intervention, but the elements of housing first were there. We did a fidelity study, for example. We did an effectiveness study, and we even created a comprehensive toolkit for scale-up. And this was important for policymakers to have local data. So Housing First had been demonstrated to be effective in the US, but Canadian policymakers wanted Canadian data, and so we were able to generate this data. Within the first 12 months, we generated some pretty strong findings. For example, the treatment as usual group, so TAU, cost the system $99,000 in terms of they used services, they used shelters, they were arrested, they went to hospitals, etc. So they cost an average of $99,000. Individuals in Housing First cost an average of $55,000. If we add on the cost of the program, which was $19,000, there was still a cost savings of $21,000. Now this for a subgroup of Housing First participants. They were individuals who came into the program and were using services frequently before they came in. And so the evidence was impressive enough that the federal government actually adopted a Housing First approach and funded Housing First to the tune of $600 million over 5 years. Moreover, that evidence was also used in Ontario to be able to secure support services and housing for those who were in our randomized trial in Ontario alone indefinitely, so that when the trial ended, individuals who were in the program wouldn't be kicked out. So we had rigorous implementation. We also had, we had rigorous implementation evaluation, and that helped to guide the future implementation of these programs that would now be scaled up all across Canada. And I will say that one of the key drivers of success is the partnerships that we established early on in this program to make sure that those who needed this evidence were going to hear about it right away and hopefully act upon it, which they did. So we had advisory groups who were comprised of policymakers and decision makers. We kept the federal government apprised of all of our early results on an ongoing fashion, and that led to this success. So as I mentioned, we had a rigorous process evaluation, and that helped us design a toolkit. So there's a fairly extensive toolkit for implementation, which does everything from tell you what steps you need in order to implement it, including getting partners together, getting buy-in, so not very different from establishing school clinics, but then also has listed out all the problems that each of the sites encountered when they implemented it and how they solved it, including barriers from partners, resistance from partners, and getting sectors to work together because often they speak a different language, So all of those problems are described, and the solutions we came up with are contained in this publicly available toolkit. It's very extensive and very well done. And it's designed to make sure that future Housing First initiatives are actually adhering to the critical ingredients of the program. Because often programs fail or don't perform as well because they're not sticking to the models. Another program that I get to work on has to do with the issue related to apprehension of children and infants by Child Protective Services, especially among Indigenous populations. Canada has a shameful history of taking children away from Indigenous families, starting with what was called residential schools in Canada in the late 1800s, where all children were required to go to these schools. They were taken from their families around age 4, and they were taken to these schools where later it was documented that there were severe abuses inflicted upon these children. It clearly disrupted families, generations of families, but since the last school closed in 1996, it was fairly recent that these schools were in operation. There was something called the 60s Scoop, where children again were taken away from families and they were adopted by non-native families in Canada. And then finally, some people would argue that the patterns of apprehension by Child Protective Services in Canada is continuing to carry out this work because it's very high among Indigenous families. For example, in the province of Manitoba, one year they documented that there were 11,000 children in foster care. 10,000 of them were Indigenous children, and only about 15%, I think, of the province is actually Indigenous. So there is an inequality in the practices of apprehension. And so we in Ontario are working on a program to try and eliminate infant apprehension at birth. And we're doing this in partnership with the community. We're actually modeling this program after a successful program that is occurring in Brisbane, where they too had hundreds of children apprehended every year, and they were able to eliminate totally the number of children's apprehensions by creating culturally safe Indigenous services, service integration across services that were important to help support families, and so creating a stronger set of services and system with wraparound services. And so rather than kind of focus on what we're doing, it's still early days, I thought what I would do is kind of emphasize the way in which we're partnering with the Indigenous community in order to carry out this work. Because the Indigenous community emphasizes self-determination, and they have said that research has not really helped their community very much, and they only want research which is informed by and controlled by Indigenous communities. So we're adhering to their ethical principles and research principles of what's called OCAP principles, so the ownership, control, access, and possession. It enables Indigenous communities to have more self-determination, to own the research, to determine what the research questions are. When we collect data, it's actually owned by the communities. And they also control and ensure that their communities have access to the knowledge that is generated. And so it's actually a very good model of community partnership because it gives a lot of control and power to the community partner in determining what questions are asked and answered, and also how the data are analyzed and how the findings are communicated. Okay, last but not least, I want to talk about another initiative that's come our way. So basic income is a bit of a controversial policy. Has critics on the left and the right. On the right, the arguments are that if you give poor people money, they're just going to sit around and not work. On the left, there's even critics suggesting that basic income is a way of eroding other important social protection policies, and so we shouldn't have basic income. We should just strengthen the programs that we have to make sure that low-income families are supported. Either way, Ontario has gone ahead and put a pilot in place, and so our center bid on the evaluation, and I think we're lucky that we got the evaluation. The goal of the program is to alleviate deep poverty. It's not as easy as it sounds to kind of give this money away. So for example, students who are living at home are making zero income, and they're certainly eligible for this. So this is a pilot in 3 communities in Ontario. And I'm not sure that they need the money, but they're one of the groups who are eligible for this. And so there's multiple theories of change. And so we're trying to look at the different mechanisms for these different groups of individuals in terms of how it leads to the outcomes that the province cares about, which is improved health, employment, readiness for employment. The idea is they're going to give this money to try and stabilize the financial situations of those who are living in poverty, to help them start working or working more. So we have a rigorous evaluation going on here too. There are 2 kind of scale-up sites, and then, 2 sites that are supposed to be randomized. So we're randomizing people to receive the program, and others are acting as the control. We're also doing a pretty rigorous process evaluation, and then also an economic evaluation in the end. So that just kind of gives you a flavor of the ways in which we can focus on some of the structural determinants by using research. So I'd like to summarize then. So can we improve our research? Or maybe it should say, should we improve our research? Yes, we should. We need to have more research that includes the structural determinants of health. We certainly need to have the right balance of problem-focused research, which is more descriptive, versus solution-focused research, so that we can generate effective interventions to address these issues. We need not only these evidence-based guidelines, but we also need evaluations that guide the implementation of these evidence-based guidelines, because we want to maximize the effectiveness and build up our evidence base on what works. And finally, I want to highlight that everybody has a unique role to play to ensure that we generate the best evidence to address these growing inequalities and other important health problems. So as researchers, we should really be asking the question about what we'll do differently in order to ensure that we're generating the right kind of evidence. Decision makers also have a role to play, because they should be thinking about what kind of evidence do they want to ask their research collaborators for. And then finally, students should be asking themselves, what kind of skills and competencies will you expect from your training? So I'd like to hear your answers to these questions. Thank you.